the complimentary doesn't mean for free, but okay, thank you very much, Carl, for your beautiful presentation, and thank you, everybody, for coming up here this morning. So non-invasive imaging modalities are the gold standards nowadays in many ways. But of course, I mean, you're going to see a lot of them that can be utilized in the so-called multimodal imaging techniques. I have no financial relationship with that, with the topic. And I want just to give you a little bit an outline on what we're going to talk about right now, which is a fundus autofluorescence that sometimes is a little bit overlooked in uveitis, has, you know, a certain weight. And I want to remark that is very important for our assessments. Optical coherence tomography, we're going to have a bite of the OCTB scan because it's very well known nowadays. DMFAS a little bit. And oh, thank you very much. Thanks a lot. You see, he's a good friend. And the ultrasound techniques that sometimes are necessary because all the beautiful fancy tests that we can run in the clinic are not possible given the fact that we have immediate opacities, and the angio-CT, of course. So autofluorescence is something that has been studied broadly along the years as a natural emission of light by biological structures. It's very well known in, in biology science, and as you can see, you know, there's the natural production of the autofluorescence also in some very interesting, beings. You can see also that you can have that one, which is not really autofluorescence, but, you know, be careful with the sun, particularly when you live in, if you live in Abu Dhabi like I do. So it's important that the autofluorescence is a physical property of the retinal pigment epithelium, and you can pretty easily understand on how this can vary when you are in front of an inflammation. So what should we know about fundus autofluorescence? Well, of course, we know that there are different machines with different potential wavelengths, so it's important to understand, you know, what we're looking for and the kind of machine that we have, you know, available in the market. Of course, I have no time to go through each and one of them, but it's important to understand that there is one thing that you have to pay attention to, is the fact that when you want to study the autofluorescence, so you have the hyperautofluorescence, which is increased RPE lipofuscin. So this is something that can be pretty easily observed in multiple different potential posterior pole inflammations. And you have the hypoautofluorescence, which means the reduced or absent RPE lipofuscin. This can be also provoked by blockage. So if you got blockage, of course, you have a hypofluorescence, and if you have, you know, some active inflammation, you can have the hyperautofluorescence. There's one thing that you have to pay attention to once you perform this, is that you can have a hyperautofluorescence like this. So you see the fundus color picture of an optus, and then you perform the fundus autofluorescence, and you see that there is a clear hyperautofluorescence in this picture on your right side. One thing that is important is that this is possible only if you run the autofluorescence before you have multiple different pictures, because otherwise you can have the effect of the glitching, which can mask the potential outcome of your test. So now, it is important also to see that this can be applied in multiple different diseases. This is another example, which is an acute placoid multifocal posterior pigment epitheliopathy, that to me is like the supercalifragilisticexpialidocious, because it's very complicated, but PMPP is very nice. So you can study and you can see how there are clumping of cells, and you see also the hypoautofluorescence for those areas that are affected. So you can see a mixture of the different presentation of that pattern, and you need to be very careful, because even though it is disclosed to the PMPP as a favorable outcome, I don't really think that this is the case, and you need to monitor very tightly the patient, as Professor Herpert said before. Remember, so the bleaching phenomenon, and try to avoid it to run a perfect test. And so try to be perfect. One thing that is very interesting is that sometimes, you know, appearances are deceiving. So when you look at pictures where you can pretty easily understand that you're in front of a potential inflammation, of course you need to use every kind of tool that you have available in the market or available in your clinic. Because if you stay in a very well-equipped clinic, well, you can have everything you want and you're blessed, but sometimes you are in the very far periphery hospital and you need to understand what you can do for that patient. Try to use whatever you could. And of course, OCT is one of them. Why? Because, you know, now it's more available in the market because the costs are going down, and you can have a very interesting observations running a simple B-scan OCT. In the very early beginning, OCT has been used for retroretinal surgery, studied in AMD, multiple different studies. Now we have the dissection even of a single cell to understand what is going on in AMD. It's AMD. And then diabetes as well, of course, but posterior pole uveitis came later, and now we know much better what is going on. So we went from the time domain OCT that was very rudimental to the beautiful swept source OCT, and now we can have also beautiful pictures like the one at the bottom of your right side, where you see that you can even picture the entire eye somehow. So now, for the B-scan OCT, you have pictures like this. Now, I have Zohar here in front of me, and she's going to talk about, vasculitis. I want to steal the time for her, but I want to tell you that when you look at something like that, it's pretty easy. I mean, this is a frosted branchiangiitis, and this is a typical frosted branchiangiitis you may observe in some cases when you have flu, and this was a kid. When you look at this, you cannot tell that much. I mean, you see that there is a very inflamed, very inflamed vessels, but, the macula doesn't look that bad. But when you perform the OCT, you can see that you have a clear cystoid macular edema with subfoveal fluid, and this is very similar to the Rialto bridge. So the morphology is something that is very important, and B-scan ultrasound is a beautiful way to try to picture that. But it's important also to see on how you can match the systemic features, where you see, in a case like this, which is pretty obvious of EKH, because you have a clear clinical picture on this, and you see that you have a very thickened choroid, and you have subretinal fluid, and you have no DOPS. Looking at also that the wrinkles of the retina, given the potent inflammation that the patient is experiencing right now. So it is important to see that in the treatment follow-up is important too. You can see baseline like this. This is a very old publication that we made a long time back for the use of Humira for the first off-label use in a pediatric patient, the first and after treatment. I mean, there's nothing to tell. It can give you a lot of information on how you can be efficient and efficacious in trying to control the inflammation. But can OCT be sufficient in raising the suspect of a specific disease? Well, when I look at a picture like this, you can see that there is a pale area on the macula, and you see that there's certainly papillitis. When you look at this, well, at that point you have to write a suspect, and I'm very happy to tell you that the diagnosis is very straightforward, as syphilis. When you look at pictures like this, when you see the pseudo-disappearance of the photoreceptors and you see irregularities at level of the retinal pigment epithelium, you have to have no DOPS. That's the diagnosis of syphilis. You can run all the tests you want, you're going to find out the syphilis. So that's syphilis. I don't know if I told you that it's syphilis. Anyway, so that is a publication that we made a long time back with my colleague Francesco Picchi, who was one of the main advocates for this. I can tell you that it's very important to tell that for the first time in 2014, so exactly 10 years ago, I used to be young at the time, we encoded and we identified the clinical features for the diagnosis of syphilis. But of course, you can have also other kind of tools. So this is not a very sophisticated, super modern OCT. This was the Optos I had in my clinic, and as you can see, there is an intraretinal lesion over there. And when you look at this, you can very, very clearly see that you have a certain lesion in the retina that is called the punctate outer retina toxoplasmosis support. So when you see something like that, just write a suspect. And of course, there's more to come, and my colleagues later on are going to tell you what. So, to be honest with you, in some cases we can have some slippery slopes. So on the top you see that the pattern of presentation of this very old OCT by Guagnini in the publication in 2007, and the bottom one is the one that Natalie Cosso presented, are very similar. But the one on the top, is toxoplasmosis, the one at the bottom is lymphoma. So not always the pattern can lead you where you want to be, so be very careful and run all the tests are necessary to try to understand whether you're standing in infections or a potential malignancy. Now, in some cases, you need to understand whether you can study the vitreous, and Pesikin studied extensively more at the hospital. You know how the presentation of the vitreitis can be also evaluated and ranked in different potential severity rankings. And as you can see here, this was a study that was done 10 years years ago, and the progression of that has gone on and on and on. It's important also to see what we can do with in-phase CT. Well, to be honest with you, I don't use that very much. In-phase CT is very interesting with the new machines, particularly Plex Elite. We can run very accurate analysis in different layers, and we can have a very dissected and very precise segmentation. But of course, you can study on how the topography of the disease is involving the different parts of the retina, and then at that point you can understand also how the relationship is between the retina and the vitreous in terms of the inflammation standpoint. What about the anterior CT? It's true that we are talking about posterior CT, but it's important to understand that it has a role. So it's important to see how you can study the morphology of that, so you can see whether you have a Busaka nodule that is creating a huge inflammation in the back of the eye. As you may see here, you can see pretty easily the bump on the anterior segment. And this is very important to quantify how much the inflammation can affect the anterior segment of the eye. Now, there's a lot of questions on how much we can improve, and of course more to come with the new OCTs that we have available in the market. And our team is studying something. Next year, come and I promise you, I'm going to show you something interesting. High-frequency ultrasound biomicroscopy, UBM. Well, we use it, but certainly with the OCT, we have two techniques that are very similar but not identical. So certainly the UBM can give us other kind of measures that can help us to understand the potential involvement of the different segment of the uveal tract in the anterior segment. I like to mention Tao Tran, who was the very first one a long time back in 2001. Actually, I met these guys from Switzerland at that time, and I can tell you that in 24 years many things have happened. It's important to know that sometimes you say, well, did you perform a B-scan ultrasound? Yeah, what a B-scan ultrasound? We got the new machines, but super beautiful. Well, but when you have immediopacities, it's very important to know what you're looking for. So when you have no view for the posterior pole, vitreous retinal tractions are not visible, or the orbital involvement in some cases is important. Having a good technician for the B-scan ultrasound or for ultrasound in general is very important to run potential very tough diagnosis. And of course, the posterior scleral involvement, remember the T-sign for the posterior scleritis is very important, and with the B-scan ultrasound you can do that. Now, the application of optical coherence tomography went broader than the mere B-scan cut, and of course we went from this to this to this, and now we can see an even broader view when we have the new machines that are able to have a reconstruction of the imaging of the vessels of the retina. Now, while this is very interesting, and I can tell you that it's very important on how to utilize the technique, wisely and well, I can tell you that this cannot, are you happy that I'm saying that, Carl? Cannot replace fluorescein angiography. Why? Because you cannot see the leakage. You can study with MFAST the potential thickening of the perivascular area, and you can have the map of that, but the accuracy is not yet so accurate and good as the fluorescein angiography. So think about that. You can use it when you want to study the ischemia and to see on a regular basis whether the patient has ischemic retinal vasculitis. You can use it, but be careful because you have not to be overconfident on the technique for the angio-OCT. Wide field OCT in active TB. Well, this is an ICGA. And this is the superimposed image for the Plex Elite for the choroidal involvement. I would say that they are very similar. I can tell you that ICGA cannot be replaced. Of course, we still use that, but we are now discovering the accuracy of the new angio-CT that can allow us to have the choroidal exploration, and that's the next perspective. We have done a retrospective study in 2020, proving that the correlation between the inter-observer analysis between the two observers was very, very similar, or even superior in the group that discovered more potential choroidal granulomata in the group of those who were the analyzers for the angio-CT. And we also went very accurate in trying to see with the Bland-Altman analysis, showing that there was no difference between ICGA and OCTA. I do agree that this is not available for everyone. Certainly might be a perspective. For those who do not have the specific machine, don't try to do this with any other machine because you know they're not able to. There are coming up others in the market, but of course if you have ICGA and you don't have Plex Elite, certainly you cannot tell that you can get rid of the ICGA. Perspective study that we did from our group in Abu Dhabi, and we had a publication with a group of Milan. We proven prospectively that by using the machine in a prospective trial, the results were absolutely overlapping the one that I showed you before. Now, what are the take-home pairs? B-scan OCT is the gold standard in uveitis assessment, no matter what. I mean, it's absolutely important to understand that this technique is becoming probably the gold standard for the regular analysis for the posterior pole exploration. FAF is a safe and very useful tool, so just don't forget that you can use it. B-scan ultrasound can be an extremely useful ancillary test if you cannot see anything in the back of the eye, or if you're uncertain that there might be a potential vitreoretinal traction in the periphery. And angio CT represents a powerful and safe new tool yet to be explored, and more to come. So I invite you to come in 2025 for our course in uveitis here. Thank you. And now, just give me 1 second just to announce the next speaker.